Hi everyone, my name is Diana and my project is looking at nursing adherence to the adult analgesia and sedation protocol in mechanically ventilated non-trauma ICU patients. So a little bit of background for you is that mechanical ventilation is required for various illnesses where a patient's lungs aren't able to work on their own. Historically, the decision to wean was based off of staff judgment, but is now influenced by sedation and analgesia protocols using scoring tools such as your Richmond Agitation Sedation Scale or RASS, or Critical Care Pain Observation Tool, or CPOT. So adherence to the sedation and analgesia protocols can actually affect patient outcomes such as length of stay or time on mechanical ventilation. It's been observed at Legacy Health East sites that sedation rates are being increased overnight despite undocumented RASS scores being within RASS goal. So the primary objective of this study was actually to review nursing adherence to the sedation and analgesia protocol in the mechanically ventilated non-trauma ICU patients within our Legacy Health East system. So the primary objective was looking at when the patient was and was not at RASS goal, the percent of occurrences where adjustment was made to sedation rate. The secondary objectives included the primary objectives just broken down into shifts. Additionally, we also looked at analgesia given alone or in combination with sedation, any changes in CPOT score, and the percent of occurrences where analgesia was given, and then lastly looking at appropriate frequency of adjustment for dexmedetomidine. So this study was conducted as a multi-center retrospective electronic chart review of 75 patients between February 14th through December 8th of 2020. RASS and CPOT scores were assessed every 4 hours per protocol, and adherence to protocol was reviewed for every 8-hour shift. Changes in any RASS and CPOT scores were compared to the patient's MAR to review if any changes in sedation rate was made, if analgesia was given, or both. We included any patients who were 18 years or older who had non-trauma given propofol, dexmedetomidine, midazolam, or any combination or switching of the agents for sedation, and also given hydromorphone or fentanyl boluses, drips, or CAD pumps for pain. So the figure on the top left is actually our primary outcome. So the percent while not at RASS goal versus the percent while at RASS goal. So as you can see here, there was 417 occurrences out of 1,077 where the patient had an adjustment made. Whereas on the right, there was 97 out of 975. On the figure to the right of this is just the left side figure just broken down into shifts. And then down on the bottom left is looking at analgesia if given alone or in combination, broken down into shifts when the patient was not at their RASS goal. Additionally, on the right, we were looking at CPOT only and if they were given analgesia, and this was broken down again into shifts. So just a little bit of discussion is that the percent of occurrences where adjustment was made while not at RASS goal was less than 39%, or that 417 out of 1,077 occurrences when we expected that to be 100%. On the flip side, the adjustment was made while at RASS goal was 10% when we expected that outcome to be 0%. There were a few limitations to the study, the first being patients weaning off their ventilators can actually kind of skew this data, and that's because there was no definitive way for us to know when weaning was occurring. Additionally, nursing staff reporting multiple readings during one shift, so they could have recorded 10 readings within a 5-minute span. Again, using these subjective rating tools like RASS and CPOT. And then lastly, intensivists and respiratory therapists verbalizing any sort of change without documenting that in the electronic health record. So to conclude, adherence to the sedation and analgesia protocol was less than 40% in patients not at RASS goal. However, there have been undocumented factors that led to deviations from this protocol, and investigating these undocumented factors and their impact was not within the scope of this project, so a follow-up study may be required to find the causes of these deviations from protocol. Future suggestions include consistent documentations from the intensivist and respiratory therapists on new goals and when weaning was attempted. Additionally, education to nursing staff that analgesia alone or with sedation can be utilized instead of sedation only. Thank you.